Hello and welcome to another Facebook Live broadcast with MedStar Health. My name is Sarah Ridenauer, and today I'm joined by MedStar Health neurologist Dr. Elliot Dawson, neuroendovascular surgeon Dr. Paul Singh, and nurse coordinator Ashley Phipps. Today we're going to be talking about strokes, the different types, how they are treated, and if they can be prevented. The month of May is National Stroke Awareness Month, so if you've ever wanted to better understand strokes, then stick around. Share this broadcast with your friends, and please ask your questions for our experts in the comments below. So thank you all for joining us today. Before we get started, I want to go around and if you all could kind of give a little introduction of yourself and talk about your specialty and the work you do here. Dr. Dawson, let's start with you.
Sure. Thanks again for having me on the event. I'm always happy to kind of share the good news of what's happening at Franklin Square and MedStar Health at large. Part of the reason I think for this is that the American Heart Association, the AHA, annually has May as its Stroke Awareness Month. So I think that's a great opportunity for us to help people understand what stroke is, to have a format for people to ask us questions. That's why we're here, and to provide that service to folks. I'm a Chicago native, but moved here in 2020. My wife and her family are from Maryland, and by training, I am a vascular neurologist, which means I've trained in adult neurology in an additional year of training in stroke or vascular neurology. I am the chief of the division of neurology here and also the medical director for the stroke program here at Franklin Square.
Great, thank you. Dr. Singh?
Hi, it's nice to meet everybody. Thank you again for inviting us to talk. May is always a very special month. It hits home because it's Stroke Awareness Month, and right now is a very big time in Franklin Square as we are growing for stroke care for the network. And endovascular treatments for stroke are these days cutting edge, and they're really game changers for how stroke patients do from when they hit the door to when they leave and how well they do long term. So we're excited to talk more about that today. A little background on myself. I'm also neurology trained. I'm also vascular neurology trained as well. I was also trained in neurocritical care. And then after neurocritical care, I went on to do neuroendovascular surgery up in New York City at Cornell. And then I went on to practice and have been lucky enough to build 2 or 3 comprehensive stroke centers along the way. And when I was given the invitation to join Franklin Square back in 2020 to help launch endovascular over here, I couldn't skip the opportunity. There is a growing need in the greater Baltimore area for care of stroke patients. And it's been exciting what we've done over the last year here. So more to come on that during this Facebook Live.
Exactly. Thank you. Ashley?
Hi, my name's Ashley. I am the stroke program coordinator here at MedStar Franklin Square. I have a background in emergency medicine and critical care. I've been with this program since the beginning, so it's been really exciting to help grow this program and see where it goes.
Perfect, thank you. Well, thanks again, everyone, for joining us today. Dr. Dawson, can you tell us a little bit about this stroke program?
Yeah, so like Ashley was mentioning, we've had a long history of success here, and MedStar Health identified that our local geographic area here outside of Baltimore really had, frankly, kind of a gap in care and services that were available to our community. And so MedStar Health made what I think was a very smart and long needed decision to invest significant resources, bringing in expertise and investing in the hospital and the community here to help up the game essentially for our stroke program. So, our mission here at Franklin Square is a commitment to provide the highest standard in healthcare from one day to the next. And part of what that looks like is investing in our stroke program here. And part of that step then is to increase our awareness and capabilities to care for stroke patients, which is why we are transitioning from being what's called a primary stroke center to hopefully a thrombectomy capable stroke center. And ultimately our goal is to be a comprehensive stroke center.
Mm-hmm. And what does it mean to be a thrombectomy capable stroke center?
That's a great question. I may have my friend Ashley here give us a bit more detail, but in short, the thrombectomy capable is a center where people can help remove clots, and comprehensive stroke centers deal with more than that, including head bleeds. But Ashley, do you have anything you can add?
Sure. There's different levels of designation within the state of Maryland and accreditations within the Joint Commission. A primary stroke center, generally those centers give your first line of acute treatment for stroke, which is IV alteplase. Some facilities use a drug similar to that. And then you advance to the next designation, which is your thrombectomy capable stroke center. And at your thrombectomy capable stroke center, you're able to offer an additional line of acute therapy for those patients, which is the mechanical thrombectomy or endovascular treatment. And then from there, you can even advance to a comprehensive stroke center, which can treat any type of stroke.
Okay, thank you. And how does the program at Franklin Square fit in with MedStar Health as a whole? And what is the benefit of a system approach for patients?
This might be a great place for Dr. Singh to join in. Part of what he does with endovascular care is help coordinate amongst the systems within MedStar Health for how we have patients come to Franklin Square and how do we also provide education, feedback, and resources to folks at the surrounding MedStar systems. Dr. Singh, is there something you can add for that?
Sure. I think we've been talking about Franklin Square a lot, but when you think about MedStar as a whole, there's hospitals of different designations throughout this group. For instance, we have Harbor Hospital, Union Memorial Hospital, we have MedStar Montgomery Hospital, just to name some of the ones in the greater Baltimore area, which are primary stroke centers. Not every place can have the higher capabilities because of the intense resources needed, not only on a physical plant level with having a machine that can do these things, but with the expertise. And so we try to centralize that expertise at certain centers. So in Baltimore, Franklin Square is that neurosciences center of expertise, as the same thing in DC would be Washington Hospital Center or Georgetown. And because we centralize those resources, we're able to provide patients in the greater Baltimore area a central location to receive this upper level of neurosciences type care. So triaging through the network, communication with our primary stroke centers, to make sure that these patients get to here as fast as possible to get these more cutting edge procedures or see the experts in stroke and ICU, such as Dr. Dawson, in a timely fashion is really, really important. That's what we try to work in-house to make sure it happens smoothly and seamlessly. One additional piece is that this transportation between hospitals is quintessential. We always say time is brain. So if you can take time off of getting a patient from MedStar Montgomery Hospital to Franklin Square, well, that's ideal. And so they've invested in a helipad here at Franklin Square, where we can actually have patients flown in between our sister hospitals to get here, have their thrombectomy, have their aneurysm treated, and they can go home in a better place where they came in.
Wow, that's awesome to hear. And shifting to talking about strokes specifically, what makes a stroke so scary? Like, what exactly happens when somebody is having a stroke?
I can take that one, but I also want to add a bit more too to
Yeah, of course.
take the lead from what Dr. Singh was mentioning. So I want to also mention that Good Samaritan Hospital here in the Baltimore area is a fantastic neurorehabilitation center, and that's the preferred place where we send folks who unfortunately have suffered a stroke but still have needs for rehabilitation. I know that we take things seriously and follow the data, and things like patient satisfaction there are actually higher than the state average. In the world of rehabilitation, they also follow metrics called gains per day. This is how much does a patient improve in terms of their function, and that is actually higher than the state average as well. So the Good Samaritan Hospital is really, I think, a source of pride for us as a system. And I feel comfortable knowing that when a patient has come to Franklin Square, unfortunately with a stroke, that they're going to continue to receive excellent care at the Good Samaritan. Us ultimately becoming a comprehensive center means that we have more complex neurologic patients here. We have greater level of expertise. So what that does is that helps education for future doctors and nurses and other clinicians as well. We become another resource for the MedStar Health system to help train people and expose them to disease and how we treat people. So that's another way that Franklin Square can add to our system at large. And then that also means that we also become a center for research as well. So potential trials that we have interest in is how do we reduce the impact of head bleeds when they come in with the medicines they use. And there's active ongoing research as well on the medicines that can help reduce the disability and impact of stroke when people unfortunately can't receive the very important medicines that are available within a limited time frame. So in terms of education, resources, research, and providing resources to our community at large, that's what becoming a comprehensive stroke center and being a real service to the MedStar Health is what I think we're here for. Stroke is scary, I think, because it happens out of the blue. It's unexpected. Back in antiquity, back in ancient Greece, if you read old books like that from Hippocrates, he was describing people who had a stroke or apoplexy of the brain the same way. There was no warning sign, and all of a sudden someone had a real problem. Their face was drooping, they couldn't speak, they couldn't move one side of the body, their vision had gone out, they had a terrible headache. And that can be scary. Now, because the brain is involved, a patient may not realize at the time, but when you talk to family who are present, they're certainly terrified when that happens. I think what I see as well, and I'm curious to know what Dr. Singh or Ashley see from their experience or what they know from the data, is that what really becomes scary is after the stroke has occurred. It's maybe day 2 or 3, and a patient has realized that they still can't use their right hand again. And they're wondering, how am I going to go to my grandchild's wedding that I've been preparing for and that's been pushed back over the 2 years because of COVID? Or what is this going to mean in terms of me being able to support my family? I think those are the reasons why stroke is particularly scary. But on the flip side of that, the real unfortunate part is that oftentimes when people are suffering from a stroke, it doesn't hurt. So what we often hear is that people want to wait it off, and it can be an inconvenience to come to the hospital. I get that for very practical reasons. But what I certainly want to communicate to people is that in stroke, the brain is dying. Brain tissue is dying. And so that can have real consequences for people. And that's what I think is often scary for stroke.
Yeah, I mean, I'd echo this very similar sentiment. And when I describe a stroke to a patient that either hasn't had a stroke, and we're talking about risk factors, or one that's had one that's recovered from it, a lot of times they won't realize exactly what happened if they've recovered well. And the easiest way I analogize is a heart attack. A heart attack is painful. When you have chest pain, you know something's wrong. You call 911, you're fearful of your life. Well, a stroke is a heart attack of the brain. But because pain receptors work differently in the brain, it is painless for the most part. Not all strokes, but for the most part. And so if you don't have any pain, if you don't have a headache even at the onset, which is true for some strokes, sometimes you will wait it off. You'll say, well, let me just see if it gets better over the next few minutes. But every minute that goes by, brain cells are dying. And it's not like if you cut your arm and you bruise your arm, where your arm is resilient and it'll heal up. The brain is not as resilient. And we go by the moniker of saying, for every minute that goes by, 2 million, upwards of 2 million brain cells can be lost. So painless, no pain, wait it off, you're losing brain. The faster you can get to the hospital to receive acute IV medications or acute therapies that we can provide in the lab, the higher the likelihood that you'll actually leave the hospital with higher neurological function. And this has been well studied when it comes to stroke patients. So time really does matter. And it's sometimes I actually wish that there was pain involved with it, because people would respond more quickly.
Quicker. Yeah, exactly. Yeah. So my next question, and you kind of touched on this a little bit, was part of it was going to be, why is it important to get to the hospital as soon as possible? But the other part was the signs and symptoms of stroke. I know the acronym BFAST. Can you explain that a little bit?
Of course, of course. So like Dr. Singh said, time is brain. So we use the acronym BFAST because you want to act fastly for stroke. The B in BFAST stands for balance. So if you lose coordination, you're having difficulty walking, or you're super dizzy and you can't walk because you're dizzy, or sometimes you're even completely weak on one side, so you don't have that coordination to walk, that's one sign of a stroke. The E stands for eye. So you have your visual differences. You could see double vision, you could lose vision in an eye. Those are signs of a stroke. The face stands for facial droop. So you may see the droop on one side of somebody's face. It could be the whole face or just part of the face. The A stands for arm. So if there's any weakness to the extremity, that could be a sign of a stroke. And then there's speech. Sometimes the speech sounds slurred. Sometimes they can't get out what they want to say. What they're saying doesn't make sense to you, or they can't understand what you're saying to them. The last letters T stands for time, and we want to emphasize that you want to call 911 and get to the hospital right away, because those treatments have time windows, and we want to make sure that we're treating that brain quickly and saving as much tissue as possible.
Great, thank you for explaining that. And so I want to talk about the different types of strokes. Ischemic stroke, is that how you pronounce it? I think I totally messed that up. But can you talk about the different, and like if they all share the same signs and symptoms, or if it's different for each one?
Yeah, so you're very close. Ischemia or ischemic stroke is I think how
Totally
we
butchered that.
often will pronounce it, but we won't hold that to you. No, but before I think it's essential and extremely important to talk about that. I want to come back to your last question though, because I also want people to know that we recognize at MedStar that caring for stroke is not just knowing the warning signs and encouraging people what a stroke looks like and why you have to act quickly. Your brain is dying, right? It's also kind of taking care of folks after that acute period of illness and helping them for recovery. So one thing that MedStar offers also is stroke support groups that we have in the DC area and also in the Baltimore area. Ashley Phipps has been participating in that likely for years now, and I think it occurs on a monthly basis. Ashley, I'm curious, what do you hear from folks in the stroke support group, or any feedback of what their experience was like when they were having a stroke and how that impacted them?
We do. We have a great stroke support group here at MedStar Franklin Square that we do. We collaborate with Good Samaritan Hospital and their rehab department there. So we get a really good turnout of patients. A lot of them do describe it as scary and difficult. However, most of them are really resilient. And after many years, through the support of other family members, friends, support groups, other people who have had stroke from support groups, they find that everything does end up working out, and they do okay. So the support groups are super helpful in helping patients overcome some of the challenges and issues that they face after having a stroke.
And Sarah, one thing it's abundantly obvious since I've moved to Maryland is that people here really do have a wealth of resilience here. And I know that things have been difficult for everyone because of COVID. But I think Marylanders have something special going on where they are able to come together, where there is a strong sense of community here. And I want us here to help folks out, right? Life is hard enough. And I think one thing we can do to help people in our communities is to give them a helping hand. And that's why the transition of care from being into the hospital to leaving is something important too. But I think is often a gap in healthcare because people need help after they leave the hospital. It's a lot of information when you come to the hospital. It's a lot of learning, and not everyone is in the mood to hear us talk about what's ischemic and hemorrhagic stroke. But I think over time, people like to have the option to come back and say, hey, what exactly happened? I'd like this not to happen again. And can you help me with that?
Dr. Dawson, it's funny you say that because, sometimes when we do thrombectomies on patients and patients do recognize the signs and symptoms of stroke in a timely manner and they get here, well, we're fortunate enough to open up the blood clot in the brain and restore blood flow where they may not have much in the way of residual stroke deficits, where they have weakness. And many times they won't realize what happened. And they won't realize how severe it actually was. They won't realize that it was a heart attack of the brain that they had. And so that education, as far as what caused it in the first place, those risk factors, high blood pressure, high cholesterol, smoking, why are they so important? Why do they lead to this? And why do we need to address it? Because the next go around, what if they don't make it in time to the hospital? And I think that's really important to stress, just as you did, in that we need to have that education out there for our patients in Maryland. And I think that's why we're doing this during Stroke Awareness Month. Of course, we want to get that word out so that everybody knows about this. And those risk factors are obviously really important. I know we'll touch on them more later. I'm sure Elliot and Ashley will do that. But you did have your question on ischemic and hemorrhagic. Elliot, were you going to touch on that? Do you want me to touch on that?
Yeah, no, I'll say what I normally say when I'm talking with patients in the hospital, and please kind of feel free to add in. I'm actually kind of curious to know, how you like to describe as well. So, right, what we're saying is that understanding what stroke is and why it occurs is essential, because that helps prevent strokes in the future. So in general, there are two different types of strokes. If you want, as I describe it, kind of as a big picture, one is called a hemorrhagic stroke or a bleeding stroke. And that's essentially when there's been loss of integrity of a blood vessel and blood is where it's not supposed to be in the brain. So that's a hemorrhagic stroke. Ischemic strokes are the far more common type. I think the data shows that around 80% or so of patients who have a stroke have an ischemic stroke. What happens there? Well, what is ischemia? Ischemia is essentially loss of blood flow, and that loss of blood flow then causes death of brain tissue. So different things can cause that ischemic process. Sometimes there can be disease within the integrity of the blood vessel itself, and the blood vessel blocks itself off essentially over time in a chronic process. Other common causes of stroke can be a clot that has entered the circulation of the brain from outside the brain. So we will often see people who have cholesterol disease, often here in the neck and the carotid arteries. That cholesterol plaque can break off and then cause a blockage up here in the brain, and that portion of the brain starts to die. We'll often see that the heart can be a source of clot as well. A very common risk factor is irregular heart rhythm called atrial fibrillation. What happens in that heart rhythm is there's abnormal blood flow. And when there's abnormal blood flow in the chambers of the heart, then a clot can form in the heart itself. Then obviously the heart is pushing blood throughout the body. So that clot escapes the heart and can again travel and work its way up through the arteries into the brain, causing a blockage there. So that's how I describe ischemic or bleeding, hemorrhagic or bleeding strokes or ischemic strokes. There's a lot more we could go into, but that's kind of how I would start. Dr. Singh, what would you add?
Yeah, that's pretty much exactly what I would say to my patients as well. I usually say stroke is a big word. It encompasses everything, whether it's bleeding in the brain or not bleeding in the brain. But the take-home message from it is that whether it's bleeding or non-bleeding, you're not having oxygen and blood sugar go to the brain when it needs to get there. One reason could be a blood vessel ruptures open and it leads to bleeding in the brain, but that sugar, that oxygen is not getting there. The other reason would be a non-bleeding stroke where you have a blockage of a blood vessel and that's inhibiting blood, which means no sugar and no oxygen going to any given area of the brain. Both of those can look the exact same way when you come into the emergency room. You might not know which one you're having until you're here, but both are the same amount of emergency. So they're just as time sensitive, whether you have a bleeding or non-bleeding stroke. But that's the one thing. And then numbers wise, in the United States, we see about 800,000 strokes overall every year. And in about 80%, 85% of those are ischemic, just as Dr. Dawson mentioned. Metropolitan areas tend to have a higher incidence of high blood pressure. And when you see that, those areas, be it the Baltimore area or the New York area or the DC area, have a much higher percentage, upwards of sometimes 30 to 40% hemorrhagic stroke in those populations as well. So for the sake of education, time is still brain. Whether you're having a hemorrhagic stroke or an ischemic stroke, you still need to call 911 or you need to get to the ED as soon as possible for potential life-saving therapies.
Yep, exactly. Thank you for that. I'm going to pause real quick and just say, everyone, thank you for joining. Thank you for tuning in. I'm joined today by neurologist Dr. Elliot Dawson, neuroendovascular surgeon Dr. Paul Singh, and nurse coordinator Ashley Phipps. And we're talking about strokes, the different types, how they're treated, and if they can be prevented. As we said earlier, the month of May is National Stroke Awareness Month. So if you want to know more about strokes and better understand them, stick around, share this broadcast with your friends, and please ask your questions for our experts in the comments below. Getting back into the questions. So what stroke procedures are performed in an OR versus the ED versus an interventional suite? And from the patient's perspective, does the setting matter or not really?
Dr. Singh, you want to take that one?
Sure. So, I always tell the story in the last year that one of my old nurse practitioners that I worked with sent me a snippet of a book she found. And the book was from the 1950s. And it was describing stroke care. The way they said management of stroke occurs is masterful inactivity. And this was in quotes, essentially doing nothing except for supportive care. Well, the mid to early 1990s changed the paradigm for stroke care. And we had the introduction of thrombolytic medications or clot busting medications that were given through an IV that we still continue to use to this day that are given in a time sensitive fashion. Over the last 10 to 15 years, we've had the advent of newer procedures to physically go up and remove clots from the brain. And we found that these procedures are so efficient at removing clots that they're the new standard of care. We can do these procedures to remove clots out of the brain as far out as 24 hours, and I anticipate in the future it's going to go well beyond that, knowing that the earlier that we come in is still more beneficial for removing those clots and saving viable brain. These are done in a specialized angio suite. And Sarah, if you allow me, I'll just actually, a picture is worth 1,000 words. If you allow me, I'll show you a quick picture of our angio suite here at Franklin Square, and an example of something like this.
Sure.
But I think you need to allow me to share, and I will share.
Okay. I think you should be able to now.
Wonderful. Okay. You should be able to see this just briefly here. All right. You should be seeing the screen now. That's a picture of our biplane angio suite. It looks very busy in here, but essentially we're using fluoroscopy or x-rays that are high resolution to visualize the blood vessels in the brain. And in this room that you see, there's a lot of equipment on the walls because a lot of these require specialized tools to actually get into the clot itself. Here's an example of what a blood clot looks like in the brain. And the word that we use is ELVO, emergent large vessel occlusion. It's the equivalent of a heart attack of the brain that we've mentioned before. And on this picture here on the left, what you see is normal blood vessels running in the brain, but this one blood vessel here where you can see my mouse just stops. It should continue on. There's a circle for you there. So what we do is a procedure to help remove that clot. So in this picture here, this is a video where you actually see a very flexible, soft, small catheter that's sitting inside the blood vessel up against the clot, and it's attached to a vacuum pump, and it's being removed. It's being pulled back into another catheter to remove that clot. And here's what happens before and after. I love these pictures because they're relatively straightforward to look at, even if you don't have the dense knowledge that Ashley Dr. Dawson has when you're looking at these pictures. But what you can see is the before and after. What's different between the two? And the one here on the left shows that there's a blockage of this blood vessel here. And here's a restoration of flow of the blood vessel and of the entire brain with a clot that came out here. This is just one strategy to remove it. We have several tools and devices to help remove these clots. Sometimes these blockages occur in the head. That's what we think of as stroke. They can also occur in the neck. And so when they're in the neck, we can actually open up these blood vessels with the use of stents. You can see a very tight narrowing in this blood vessel supplying the brain. And here's a stent here opening up that blood vessel.
Wow, yeah, you're right. Pictures do definitely help explain that a lot better. That made it really clear. Thank you for that. My next question is, what's a TIA?
So TIA stands for Transient Ischemic Attack. We were talking about ischemic stroke just a moment ago. In a TIA, I'll kind of break it down. So the A attack is like I was describing before, all of a sudden something is wrong. Moving backwards, that I is ischemic. So the similar process is occurring, we believe, in a TIA, where there's sudden loss of blood flow, brain tissue is injured in the process of dying, and then so people develop stroke-like symptoms. for some benevolent reason with folks, a TIA can occur where there is restoration of blood flow. And so what we see in a TIA is typically two things. One, the symptoms have resolved, hence it's transient for a TIA. And when we look at a brain scan, either often a CT or an MRI, we don't see evidence of tissue death on imaging as well. And I think it's important. I often hear the term mini stroke, and I think to me that doesn't help us as providers educate people on what's happening. Because I can imagine a mini stroke being an ischemic stroke where someone has had death of brain tissue, but the symptoms are either minimal or they entirely resolved, or someone had a transient ischemic attack. But in that sense, the brain tissue hasn't died. And I think that makes it difficult for us to provide the best care we can for patients if we don't have a good understanding of what has happened and what the impact of injury has occurred with a person. As an example, ischemic stroke, when there's been death of brain tissue, can ultimately cause scarring in the brain, and that increases the risk for other complications like developing a seizure disorder. So I think it's important for us to distinguish when a ischemic stroke has occurred versus a transient ischemic attack. I also think that understanding what a TIA is very helpful potentially to patients, because a TIA is essentially a warning sign. The risk of going forward to developing ischemic stroke, likely within days or weeks after a TIA, is higher than if one didn't have a TIA. So prompt recognition of what that is, right? It's transient. So maybe someone had symptoms that lasted an hour and they went away and they're going to go back with their busy lives. But that's really an opportunity for us to put focus on what's happening with the body to cause that process, because there are things we can do, like introduction of new medicines or certain procedures, like Dr. Singh just showed you there with the procedure in the neck. There are things that we can do to potentially prevent an ischemic stroke from occurring when a TIA has occurred. So I think it's really important to understand what a TIA is and an ischemic stroke for those reasons.
Yeah, and that kind of goes in, oh, go ahead.
Sorry to interrupt you. Dr. Dawson, when you see patients with TIAs, is there an increased risk that they're going to have a stroke in the near future, or is it just that it's one of these warning signs?
No, absolutely. I would say it's both. It's a warning sign that a patient is at an increased risk of developing an ischemic stroke, where the process occurs where unfortunately the brain tissue dies. In the picture you were just showing there, when there's blockage, particularly of the neck here and the carotid artery, people don't know when cholesterol is building up there. You can't feel when cholesterol plaque is building in the artery of the neck. But what happens, we see, is that it almost entirely blocks off the neck. And so that limits blood flow and cholesterol plaque can break off. So what can happen is a small little piece can break off when the process is accelerating and someone has a TIA. And that's a real window for us to see a patient and to refer them to you, Dr. Singh, or to a vascular surgeon or a neuroendovascular surgeon to provide that treatment of care to help prevent them from actually going on to developing a stroke.
I also think that brings up a good point about patients who experience the TIA, those patients out in the field who have symptoms that resolve, that you still need to seek help. Don't ignore the symptoms just because they're gone, because you are at a higher risk of potentially having a real stroke. So it's important to still seek help.
Yeah, that was a great question, Dr. Singh. You should take my job. You can take over now. No, but my next question was kind of related to that and talking about can strokes be prevented and what can be done at home to minimize the risk? If you guys want to talk a little bit more about that.
Sure. So in the world of vascular neurology or stroke, we often talk about modifiable risk factors. So some of the risk factors we can't modify is our age or our genes, at least today. But we do know that there are things that are highly associated with developing or having an ischemic stroke or having another ischemic stroke. And those things include what we've talked about, I know, last year, and what people probably often hear with their primary care provider, but that's because they're so important. So things like high blood pressure, cholesterol levels, blood sugars that Dr. Singh mentioned earlier beforehand, the quality of diet, the quality of exercise they have, taking medicines that we know help prevent stroke, cigarette smoke, secondhand smoke, sleep apnea. These are common modifiable risk factors that we know if we can identify them and minimize delays to starting treatment can reduce the risk of having stroke in the future. But I also want to add that what I really think is important is a transition and shift to how we think of managing chronic disease. I think for a long time in healthcare, we focused on a problem and really kind of how to give a medicine to fix a problem. And what I really find is that a focus on wellness, which is likely a new concept over the past couple of decades, is really kind of essential for us to be doing our jobs well. So, again, the paradigm is to think about diseases. So if someone has anxiety that's not diagnosed or not treated, maybe that makes it more likely for you to engage in behaviors that are unhealthy or unwise, like smoking or chronic alcohol use. And then that can lead to other problems down the line. How we manage pain chronically, I think is something that's closely tied into health and wellness. If I have chronic low back pain, it makes it difficult for me to go out and exercise. Then I develop complications of obesity and hypertension, and we're down that road again. So I think what we are trying to do here at Franklin Square and MedStar at large is really solidifying that commitment to our patients, our providers, and to our community, to also understand who is our community around us, what are the needs of our community, focusing on topics of health equity, understanding that we have a specific type of population with a specific set of needs, and then providing a tailored approach to help our community.
Yeah, that's a great point. Yeah, you're right. There is so many connections between what's going on in our body and our minds, and it all connects. So yeah, that's a great point.
Sarah, there's one thing I kind of wanted to add on to that,
Yeah.
and the risk factors are so important, just as Ashley and Dr. Dawson mentioned, and addressing those, because many of these risk factors accrue as you get older. You get more high blood pressure. If you've been smoking, years of smoking catch up to you. Diabetes can have long-lasting effects the longer that you have it. But the other thing is to remember that stroke can happen to anybody. It can happen at any age. It doesn't respect whether you're male or female. And unfortunately, we do see pediatric strokes as well. Sometimes it can be from a spontaneous reason. Sometimes it can be from an unknown cardiac or heart defect that's out there. But it's important to recognize that. And so if you have these same signs and symptoms that have been mentioned, be fast, and you're 15 years old, it should be taken with the same degree of seriousness.
Right.
You still need to go call 911. We can do many of the same life-saving treatments, not all of them, but many of the same life-saving treatments that we could provide if you were over 18. And the same thing holds true on the other spectrum. There's no age cutoff for treating. I've had patients that are living well into their 90s and even over 100 that are independent.
Mm-hmm.
And all of a sudden they have the onset of stroke symptoms, and somebody in the family was smart enough to say, call 911, get to the hospital. And we've done these procedures on them, and they've been able to leave the hospital the same way they came in. So there's not really an age threshold, because stroke doesn't pick. It can be young, it can be middle-aged, it can be older. And so just remember that same moniker of be fast holds true for everyone.
Yeah, that's another great point. Yeah, my granny, she's 98 years old and had a stroke, but was able to get treated and go back home. And things are a little different now, but she recovered. And so yeah, that's another great point. It doesn't have an age cutoff or start. So my next couple questions, I'm going to try and merge into one, just to save a little bit of time. But so we talked a little bit in the beginning about recovery and treatment after the fact. So can we talk a little bit more about that? What happens in a stroke's aftermath? What kind of support is available to patients during recovery? How long does it usually take? All that good stuff.
Sure. So I think Ashley talked about the stroke support group that we had earlier. I think one thing that we're building here at Franklin Square is what we call a stroke risk factor clinic. There is good data to show that seeing someone quickly after they've left the hospital is a prime window to make sure someone's doing okay, that questions that may have arisen that they didn't just think about for normal reasons while they're in the hospital, we're a resource and can answer questions for them. It's a way to check in, see how you're doing. And it's also an opportunity for us to kind of share what the at-large resources that MedStar has to offer folks. So, for example, in the DC area, there's a culinary program where a physician, Terry Stone, is helping teach people how to provide healthy meals. And we know from our community health advocate, and you talk to nutritionists here, that there is a real gap in nutrition as well. So offering people nutrition services. If they have difficulty managing their blood sugars, we have a diabetes boot camp here. There are a lot of resources that our system has to offer, and I think just because of the nature of being in a hospital in an acute setting, it's not possible to take all that in. So again, it's that transition of care from the acute stroke phase to rehabilitation, and then focusing on recovery, wellness, which includes, of course, preventing another stroke, but also how can we help you in order to lead what you describe as the good or leading a life well.
Yeah, thank you. Did anybody else have anything to add to that?
I'll just add that it is a continuum, that your care does not end in the hospital. And just as Dr. Dawson mentioned, addressing risk factors from our clinics here, but even more so from your PCP. This has to be a lifelong thing. Sometimes it's an awakening when you have a stroke, that you have to start taking better care of yourself, those risk factors. We are very attached to the patients that we treat here. And so if we treat a patient for a stroke here, we see them in follow-up. And I tell many of my patients that we do procedures on, you're a patient for life. You're part of us. You're part of this family here at Franklin Square, where we're going to look after you. But we also need you to do your job and take care of yourself with your PCP. But we do have the resources here now to follow up and make sure that you're on the right path. And we're always here to help out.
Yeah, and I'm sure that's super comforting for them to hear. And going along with that, is there support available for the patient's caregivers? Because I know sometimes they can be in a really tough spot and kind of, don't know what to do and look to you guys for help. So is there support for them available?
So our stroke support group is for the stroke patient as well as the caregiver. Okay. And so we do offer support to the caregiver. We have a lot of people who come and talk. We do different topics each month, and then some months we just have an informal meeting where we meet and everyone kind of brings up topics where they need help. And so we all chip in together and we work to help out those that have questions or concerns, or what can they do to help with what's going on with their life.
Great, thank you.
Sarah, can I take an opportunity, because we're running a little short. I think we're nearing towards the end here. If I can steal a couple minutes, I just want to recognize first off MedStar Health and all of our partners here at Franklin Square. It's a little unfair, I think, that only 3 people out of the entire hospital were able to be on the Facebook Live event. But I really want to emphasize, folks, that a source of joy, a source of pride for me, why when I wake up in the morning, I feel good about coming to work, is that there is a real team of colleagues here who take their job seriously and are really trying to provide that highest standard in healthcare from one day to the next. So that includes a network of primary care providers, emergency department providers. Our nursing staff is fantastic here. It's worth mentioning that we are a Magnet recognized nursing program here. And if anyone's been in a hospital, you know how important it is to have an excellent nurse. So our nursing staff, I want to recognize our neuro ICU that's led by our neurointensivist, Scott DeBoer. The neuro ICU here really helps us distinguish ourselves as a place where we can provide the highest standard of care, because that's what they do. That's all they do is treat emergencies of the nervous system and the brain. So that's a source of pride for me here as well. We have other neurosurgeons who have recently joined, our therapists, physical therapists, occupational therapists, our speech therapists, our nutritionists. It is a real team effort, and I know I'm leaving people out here, but I really want people to leave this knowing that at Franklin Square, it's the whole shebang. The whole hospital is seriously involved in taking excellent care of people. So I want to recognize them and say thank you for the excellent care they help us provide too.
Yeah, no, that's great. I think that's a great way to kind of wrap this up. Ashley or Dr. Singh, did you guys have anything you wanted to add on to that? A message that you want our viewers to take away?
No, I think Dr. Dawson summed that up really well.
Yeah, I think that was a nice summary, Dr. Dawson.
All right, perfect. Well, then that wraps up our broadcast. I know that we did get a few questions from our viewers that we didn't get a chance to get to, but I will send those along to our experts and we'll respond in the comments. But thank you for joining and asking your questions. Thank you to you all for being here and answering our questions. If you would like to see a neurologist for more on stroke prevention or treatment, please call 443-777-7320. We'll be posting that phone number in the comments as well. Thank you all again for tuning in, and we will see you next time.
Thanks, Sarah.